and they are detectable during severe flares in these patients, and they differ from conventional plasmablasts. They express latent or analytic viral transcripts, and they display distinct immunogenic profile. What is really interesting that they produce IL-10, but not IL-6. And I think we have to wait for more research in this area, whether this can be translated to CD. We have to exclude several diseases that may be able to mimic multicentric Castleman. And these diseases, it's very important, and there have been consensus criteria for idiopathic Castleman. The first step is to rule out diseases that can mimic IMCD, and I can tell you, you have to rule out a lot of diseases, because there's so many autoimmune or autoinflammatory diseases reported to co-occur with IMCD. There are possible autoimmune manifestations of IMCD, and there are conditions that resemble the histopathological findings of IMCD, and there are also some diseases that resemble clinically IMCD findings. So you have to rule out a lot before you can talk of an IMCD. So the idiopathic multicentric Castleman disease, the first step, as I told you, is to rule out other diseases that can or that may mimic histopathologically the IMCD. And the second step is to look at both major criteria, namely a lymph node biopsy with histopathological features and multiple regions of enlarged lymph nodes. And I can tell you this is pretty difficult, because the pathological findings in Castleman disease lymph nodes, they show really a wide range. And I've seen about 100 cases under the microscope, and I can tell you this is really difficult, because sometimes you have regressed germinal centers, sometimes not. Sometimes you have FDC prominence, sometimes not. The vascularity shows a broad range. So it's really difficult to make the diagnosis. High variation, there are different subtypes, hyaline vascular to plasma cell rich, and these subtypes do not guide the prognosis, but the histological diagnosis is very difficult and clearly needs expertise. And even if the expertise is evident, you will have disagreement between experts. And I've highlighted this paper because it's really an interesting paper, because only 18 of 79 reviewed cases had the same IMCD subtype selected by all three experts. And this shows how difficult the diagnosis is. And of note, almost 20% of the cases were not consistent with the IMCD diagnostic criteria. So really difficult pathological diagnosis. And you need all criteria and lab criteria. And CRP elevation, anemia, thrombocytopenia, constitutional symptoms, large spleen, edema, effusions. You may ask yourself, how can these symptoms and findings be explained? I can tell you the explanation is relatively easy. The key feature of IMCD is cytokine dysregulation. IL-6 is the mainly involved cytokine, and this can activate or trigger many human cells, hepatocytes, T cells, B cells, megakaryocytes, also vascular cells. So many of these features are explained by the cytokine dysregulation of IL-6. And what we've done, we looked at the clinical differences between the different subtypes, the UCD versus the IMCD and the HHV positive MCD. And we performed a systemic analysis of all studies published with publishing more than 5 cases to avoid publication bias. And what we found is that in almost all patients suffering from HHV-8 positive MCD, you will find constitutional symptoms, and this rate is much higher than seen with IMCD, and you also have higher rates of splenomegaly, and this may be due to the underlying HIV infection. But you will also, in contrast, you will find more renal dysfunction in patients with IMCD, and this may be due to underlying comorbidities in these patients that tend to be older than patients with HHV-8 positive Castleman. If you look at the lab findings, no big differences between IMCD and HHV-8. You see in red the unicentric Castleman. They have a considerable proportion of the patients have some lab findings, and this review was published earlier this year and highlights the differences between these 3 subtypes. So I'm just a stupid clinician, and idiopathic shows that there are many open questions, and we have the coincidence of many autoimmune diseases, psoriasis, for example, Hashimoto. Maybe there is a predisposition. There's been a very interesting case report from an identical twin pair from Singapore, both developing IMCD at the age of 42. Of note, with different severity. One was sick and one was not very ill, and there were pathogenic germline variants identified. What we know about cytogenic, molecular, and genetic abnormalities found in these abnormalities were found in some cases, but only in a subset of cases, somatic changes in about 10% of the UCD cases and 20% in the IMCD. Maybe there's an infectious trigger. So there's one report of 4 out of 25 patients with IMCD with COVID, and they showed progression of the IMCD. Scripts found in CD lymph nodes. Maybe there are some reports of Castleman diseases occurring after vaccines. And I will show you one of these patients we have published 2 years ago, and this was a 20-year-old previously healthy man presenting at the emergency unit a few days after second dose of mRNA vaccine from Pfizer. And since 2 weeks, he had noticed swollen axillary lymph nodes, fever, weakness, no previous adverse reactions to vaccines, no allergies, high CRP at admission, low platelets, high procalcitonin, high IL-6, anemia, and low albumin. And there was no evidence for autoimmune diseases or several viral infections. And CT revealed multiple large lymph nodes and effusions, and he had no endocarditis, and broad-spectrum antibiotics and high-dose steroids had no effect. So the colleagues decided to perform a lymph node resection, and the lymph node showed very typical findings, typically onion skinning in the enlarged mantle zones, and the concentrically arranged lymphocytes around the regressed General Center. But this was clearly a severe idiopathic Castleman. And this patient has received cetuximab several cycles. And I mean, it's always a question, what was this coincidence? But I think a clear argument that this disease was triggered by the vaccine was that the patient is off treatment now for more than 3 years. People with IMCD tend to have a poorer prognosis. This was not seen in UCD. The same group has evaluated several risk factors, multivariate analysis, age of more than 60, large liver, large spleen, and low hemoglobin had an impact on the prognosis, but not the histological subtype. There is the recommendation to distinguish between severe and non-severe. Severe IMCD, you need at least 2 criteria required for severe IMCD, which is an ECOG score of more than 2, severe renal dysfunction, anasarca, severe anemia, pulmonary involvement. And in the case of severe IMCD, you may consider high-dose steroids or even higher doses of cetuximab. During recent years, again, this is the China Castleman Disease Network, incredible huge numbers, 731 patients from 40 centers. And this group has evaluated 3 different prognostic subtypes of IMCD, the IPL, the NOS, and the Taffer syndrome. NOS is not otherwise specified. And the IPL with an overall survival resembling the UCD overall survival. What is IPL? IPL is idiopathic plasmacytic lymphadenopathy. And they have found, beside the better prognosis, some characteristics: younger age, more inflammation, lower albumin, more severe anemia, and even higher or elevated platelets and less renal dysfunction. And these patients tend to have a very good prognosis. And then on the other side, we have the Taffer syndrome with the poorest prognosis. And the Taffer syndrome is a systemic inflammatory disorder. It's an acronym for thrombocytopenia and Lasarka, fever, renal failure, and organomegaly. And the Taffer syndrome typically presents with only mild lymph nodes, but frequently progresses very seriously, aggressively, acutely, and it likely involves more pathogenic factors than IL-6 associated with several Sjögren antibodies. However, in Western countries, it is questioned that Taffer syndrome is an entity because there were no worse prognosis, for example, in a French cohort. So this is open for discussion. So we have 3 variants of idiopathic MCD, 3 acronyms. The Taffer syndrome with the thrombocytopenia, the NOS not otherwise specified, the IPL with the thrombocytosis. But there are no differential treatment recommendations for these 3 variants. So how to treat IMCD? And I can tell you in November 2018, 42 experts, we tried to find a consensus, and it was a long discussion. And to make a long story short, the first choice is always IL-6 blockade, either with the IL-6 antibody cetuximab or the IL-6 receptor antibody tocilizumab. And the choice depends on access, on availability, and also on the experience of the treating physicians. And in severe cases, you may combine the IL-6 blockade with steroids and increase the dose in severe cases. Cetuximab is the only approved drug in Europe for multicentric Castleman, and this has been evaluated in the one and only randomized double-blinded placebo-controlled trial ever performed in the multicentric Castleman, showing a durable response in about 1/3 of the patient. As I told you, IL-6 is the receptor antibody. It's not it's the direct IL-6 antibody, not the receptor antibody. And we've treated many patients with cetuximab. It's usually well tolerated. However, you have to perform infusions every 2 to 3 weeks. You may extend the intervals to 6 weeks, but it's a continuous therapy, achieving only durable responses in only 50% of the cases. During recent years, we have learned some lessons from this double-blinded randomized trial. There is a plateau of the response occurring after 10 to 12 months. So there's no need to continue therapy if the patients do not respond after a few months. And what we've also learned is that the IL-6 is elevated during cetuximab treatment, so it does not make any sense to measure IL-6 during cetuximab therapy. But maybe we will have some new tools to measure the response earlier, and CXCL13 levels may be an indicator of an early response, but this has to be confirmed. If you look at the treatment responses of different treatment options in IMCD, if you look at the mild moderate cases or the severe cases, you see cetuximab almost 60% in severe cases, in mild cases, and severe cases 40%. The same with tocilizumab, even lower rates with rituximab. So you have different options, but the majority of the patients will not respond to this treatment. And if you look at the treatment algorithm for IMCD, the management of IMCD, you have these 3 options: cetuximab, tocilizumab, rituximab in non-severe cases, and cetuximab, tocilizumab in severe cases. So a huge number of patients will not respond to these options. And then you have a problem, because then it's, what we call individualized further therapy and seek expert advice. And this is seen in about 1/3 of the cases. And this is really a problem. And the treatment guidelines, they provide you with some examples of chemotherapy, but they also recommend some immune modulating agents. And I want to highlight the sirolimus. Why sirolimus? Sirolimus is an mTOR inhibitor, and this is a central pathway downstream of IL-6 of multiple cell surface receptors. And this enzyme is involved and impacts proliferation, apoptosis, and it is hyperactivated in IMCD, so to a similar extent than mTOR redness, anemia, low platelets, CRP around 20 to 30. And the most important thing was that she had a severe ascites requiring punctures every 2 weeks. So, and the first thing I do with my Castleman patients is physical examination. And what was not noticed was that this lady had a severe peripheral polyneuropathy and an extremely high VEGF, which was more than 2000, and she had skin lesions. And I'm going to show you these skin lesions, and most of you will know the diagnosis because this hyperpigmentation is very typical. And this lady has a POEMS associated MCD, which was not diagnosed over 5 years. POEMS, as all of you will know, is also an acronym. The P, the polyneuropathy, the O, the organomegaly, the E, the endocrinopathy, the M, the monoclonal plasma cell proliferative disorder, and skin changes, the S. And as you may know, it's not mandatory. It's not among the two mandatory major criteria, the P and the M, but it's another major criteria. It's the Castleman disease. And this is really important. And Angela Dispensieri, I think she's the queen of the POEMS syndrome. She reports every 2 years, she writes a fantastic review on the POEMS syndrome. And she considers only cases with P and with M as classic POEMS syndrome. And if you don't have the P and if you don't have the M, the patients can be classified as having the MCD variant of POEMS. And she wrote that several published cases of interesting features are associated with MCD. Associated with MCD are likely cases of POEMS, and I think she's really right. And I've seen several papers of case reports and where it became obvious that these cases were POEMS syndrome and that the authors didn't had make the correct diagnosis. And I had several papers where I said this case should not be published at all because obviously the authors had make a mistake. Because you have to treat this MCD variant as a plasma cell disorder, lenalidomide or bortezomib, or even more intensive therapies. It's really important not to use cetuximab in these patients. So take-home message, Castleman is not Castleman. The pathology represents the final stage of cytokine dysregulation, mainly IL-6, which may cause a very colorful spectrum of symptoms. Cytokine dysregulation can be triggered by very different pathomechanisms and diseases. In IMCD and UCD, there's no clear framework of the biological reasons driving this the disease process. HHV8 is only one pathomechanism. HHV positive MCD is mostly associated with HIV. We have other various triggers, viruses, vaccines, neoplastic diseases such as POEMS disease, autoimmune diseases, and very different therapies are necessary. So if you have a unicentric Castleman excision, especially in those cases with pemphigus, it's really important to get the tumor out of the body. If you have an HHV positive multicentric Castleman, if it's HIV positive, there's no doubt you have to treat with antiretroviral therapy and then treat with rituximab. You may add etoposide, but in most cases, it's not necessary. If you have an HHV8 negative case, you have diseases to exclude and you have to treat the disease. If you find, for example, lupus or rheumatoid arthritis, and then keep an eye on the POEMS-associated MCD, because this has to be treated as a plasma with a plasma cell therapy. And then you have the idiopathic MCD with 3 different variants, the TAFRO, the NOS, and the IPL, and you have to use siltuximab with or without high-dose steroids, tocilizumab, rituximab. And if these 3 options do not work, you may use other options such as sirolimus. And I want to end with one report. And David Feigenbaum, the founder of the Castleman network, he said that this paper has put him in an identity crisis, because this was in a report published 2 years ago, a report of a case with clinical and pathological features of Castleman disease that predates Castleman report by more than 50 years. And this case had been published by Edwin LeCount, a pathologist from Chicago, in 1899, and he described very precisely the changes you see in the histopathological changes with Castleman disease. And the authors conclude that they report what we believe is the first report of Castleman, but by LeCount. And this would be consistent with the Stigler law, which states that eponyms usually honor people other than the original discoverer. And I want to end with this. I thank you all. In the meantime, we can still honor Benjamin Castleman, and hopefully this we will do so in the future. And I thank you for your attention. I'm open for questions and discussion. Thank you.
Thank you, Dr. Christian Hoffman, for a fantastic and lovely lecture. Very crisp lecture, wonderful, beautiful way of presentation. Thanks a lot. And I now request all of our discussants to please put the raise hand sign so that we can start our question answer session with Dr. Christian Hoffman. So if you can please unshare your screen once.
Okay.
So, sir, I just begin keep the ball rolling. With the advent of these newer agents like siltuximab, tocilizumab for the treatment of idiopathic multicentric Castleman disease, the beautiful articles were published before also regarding TCD therapy, that is thalidomide plus cyclophosphamide plus dexamethasone for refractory cases of Castleman disease. Are we still using that in 2024, or they are the bygone days now? With thalidomide, cyclophosphamide, nothing works like that now.
No, I don't use this agent anymore. My first choice is cetuximab because it's an improved drug. However, you have to consider the POEMS-associated Castleman. Then you have to use other. I think some of the patients responding to thalidomide had been POEMS-associated Castleman cases. So I would prefer lenalidomide today.
Perfect, sir. Thank you. Dr. Aditi Jain, your question?
Yes, sir. Thank you so much for that really lovely talk. I have been reading Castleman because I'm just seeing my first patient. Discuss that patient with you, sir. He's a 52-year-old male with bilateral facial of palsy element type, and he had bilateral cervical lymphadenopathy. And from that biopsy, we've got a diagnosis of hyaline vascular Castleman disease. I'm still waiting on my investigations, which include all the general investigations which are to be done. So I'm not sure, but at least it should be a multicentric type. He's otherwise stable, so maybe IMCD type, although my HHV8 serology is still waited. My question to you, sir, is in case it does come out to be idiopathic MCD NOS type, we don't have cetuximab or tocilizumab availability because our patients are from very poor socioeconomic backgrounds. What should be my first line of therapy? And also, sir, if I have sent the workup for Poem syndrome. However, if that comes out to be negative, how do I interpret the facial nerve palsy?
So you don't have siltuximab and you don't have tocilizumab, right?
Yes, sir.
And do you have rituximab?
Yes, we do have that.
Yeah, then I mean it's in the guidelines. It's an alternative, and I would try rituximab in this patient if it's really multicentric. If I'm right, it's not that sure if he is multicentric. Do we have signs? Do we have an elevated CRP? Do we have fever? Constitutional symptoms?
There are no constitutional symptoms, but there's bilateral cervical lymphadenopathy, and rest of the workup is awaited. CRP and PET scan and all that is awaited. He just came to me for the first time a few weeks back.
Okay, so I would wait for the results, and I mean it's not a disease. If he's clinically in a good condition,
Yeah.
It's not a disease that you have to treat by emergency. So take a careful look at this patient, how about his symptoms, his CRP, and I would use the drug which is available, and if it's rituximab, I would try rituximab.
So what about the facial nerve palsy? Do we add steroids for that? And can it be MCD with facial nerve palsy without POEMs? I mean, does that work? I mean, without neuropathy, like if it's neuropathy but it's not POEMs?
If he has no polyneuropathy, I think he has no poems. If he has polyneuropathy, I would consider poems, because polyneuropathy is not a sign of Castleman. It's a sign of poems. It's a P, and I'm always very cautious with Castleman's, idiopathic Castleman's, presenting with polyneuropathy, because this is not a sign of IMCD. It's a sign of poems. And does he have a polyneuropathy?
He has bilateral facial nerve palsy, LMNI. MRI is normal, so we don't know the cause of that, sir.
Maybe you can send me an email, and we can discuss this case further, and I would need the results of the examination.
I'll do. Thank you.
Fine. So thank you, Dr. Aditi Jain. Dr. Aditya Jandil, your question, please.
Hello. Good evening,
Hi.
Dr. Hoffman. Thank you for the nice lecture. So I have two questions for you. So first one is does duration from the onset of symptoms to the diagnosis affects the overall course of the disease, like in terms of prognosis? And the second thing is for people where we do consider infection or some virus as a trigger for onset of symptoms, how often do you see in your practice vulnerability of these patients to a second hit?
The first question, yes, I mean the time from the first symptoms to diagnosis is in many patients it's a very long time, spanning almost years. So I'm not aware whether these patients have a poorer prognosis. However, they need their correct treatment, and this is the most important thing. So a Poems syndrome associated Castleman needs a plasma cell therapy, and I've shown a case of a woman who was treated 5 years with the wrong therapy. And the second question, I've seen several patients with infectious complications, such as COVID or flu, but not a specific, an opportunistic feature. So I can't say patients treated with siltuximab, there are some reports of infectious complications, but I've never seen this. but rituximab has its risks, and you have to be cautious in patients treated with rituximab. There's no doubt.
Just one more question. Like in patients where you do not find any cause and you have ruled out secondary causes, you are suspecting some infection or some exposure as a trigger. Do you do primary immunodeficiency workup in any of those patients? Let's say somebody who is in a younger age presents with the idiopathic MCD. Is there any scope of doing that workup? Because we don't know what is dysregulating the immune system.
Yeah, that's a good question. I mean, there is a recommended workup what you have to do in these patients, and I can tell you there are many patients where I'm not sure whether it makes sense to exclude some autoimmune diseases because the patients have some overlapping syndromes. So, I mean, if I have a patient with lupus and he has a clear Castleman clinic, I would consider this also to be a Castleman patient, but so these overlapping syndromes are very difficult to treat.
And just one question that is coming to my mind, that for patients who are you showed 3-4 patients who had initially received rituximab or siltuximab, and after a year or maybe more, they required a repeat course of therapy. So, is there any role of autologous transplant in any such patients where who are requiring second or third course of therapy?
There are no reports. I mean, there are many reports on poems associated Castleman, and Angela Dispensieri, she had published a case series, and it looks pretty good. But in the idiopathic setting, idiopathic Castleman, I'm not aware of any transplantation.
Because I just wanted to know your views on the fact that now we have data, we have some data from role of autologous transplant in patients with severe lupus, severe multiple sclerosis, and many of the autoimmune disorders. So for a disorder with the idiopathic multicentric Castleman disease, where we do not have many high efficacy treatment options beyond second line or third line, then could it be a tool which can be discussed?
It could be an option, but I can tell you my impression is not the intensity of the chemotherapy is not it's not the solution, increasing the intensity. So I'm not sure whether transplantation would make sense in these patients, but this is speculation, so I'm not aware of data.
Thanks a lot.
Thank you, Dr. Aditya. So from the same note, if the patient is not responding to rituximab monotherapy, should we go for R-CHOP based chemotherapy, R-CHOP or RCBP based for such patients?
There are no controlled trials, and yes, you may write combination, at least in the HHV positive cases, the combination R-CHOP can make sense. There are some experts, and they are convinced that it makes sense to combine chemotherapy and rituximab in the idiopathic. Yes, you may use it in the treatment guidelines. It is listed to combine. You may use it in severe cases, yes. I mean, if you have limited availability of options, you have to use what you have.
Thank you, sir. So there's some question from the audience. Dr. Lee B. Sun wants to know that she has a case of HHV8 positive, HIV positive, multicentric Castleman disease. The first line of therapy should be rituximab monotherapy or to go for R chemo upfront?
I would say in most cases, in 80% of the cases, R is enough. So you don't have to treat this patient. I mean, you have to treat this patient with antiretroviral therapy, And my last 10 patients only needed rituximab. But I'm aware of patients and I'm aware of experts saying in very severe cases, you may combine rituximab with CHOP. However, the more severe the patients are, the more difficult it is to give them a CHOP regimen, right?
True.
So I would go for R, mono.
Thank you, sir. So you mentioned about adding etoposide and doxorubicin with rituximab. Is there any regimen like adding R plus etoposide plus doxorubicin? Any regimen which you favor?
It's a really good question. There are some case reports of rituximab plus etoposide. And etoposide is a drug you can take it orally. And I remember some patients, but this is almost 20 years ago, they developed severe flares of HHV8 positive MCD, and some of them they had a standby dosage of etoposide just to suppress the flare. And they took 1 or 2 tablets and they will be able to suppress the flare. But it's only small case series, case reports. I would prefer etoposide because I've made encouraging experience with this drug.
Thank you, sir. What about doxorubicin?
Maybe I would add the doxo. If you have an HHV8 positive patient with Kaposi, you have to be very careful with rituximab because about 1/3 of these patients will develop progression of their Kaposi, and this can be very rapidly. And if you have a patient, an HIV patient with Kaposi and with HHV8 positive Castleman, I would go for rituximab plus doxorubicin, liposomal doxorubicin.
Thank you, sir. And is there any role of maintenance therapy?
No data. Expert opinions, some say yes. I don't think so. In HHV8, if you have treated the disease with 4 cycles, but please, the monitoring is important. The monitoring, if you don't have the HHV8 PCR, which was very difficult for us to establish a lab, to find a lab with HHV8 PCR, but this is a perfect tool to measure the treatment response. But if you don't have it, use CRP, and then treat and use the clinical picture of the patient. You will see the patient will be better. Monitor the CRP, and I would not go for maintenance therapy, but you can treat with another cycle of rituximab if there's a true relapse of HHV8 MCD.
Thank you, sir. Another question from Dr. Tariq Ben Othman. How do you choose between sultuximab versus tocilizumab?
It depends on the availability and the experience. So if you have sultuximab, use sultuximab. If you have tocilizumab, if the patients in our country, there are many questions by phone, and asking whether the patient is in a rheumatological center. I say then you can use tocilizumab because most of the rheumatologists, they know this drug. It depends on the availability and experience. There's no comparative study. However, we in our country, we have to consider the approval. So we have to use sultuximab, but tocilizumab is much less expensive in our country, so we may also use tocilizumab. It depends on access, on availability, and on experience with these 2 drugs.
Thank you, sir. And how do you go with the duration of anti-IL-6 therapy? How much to give and how long to give?
Normally, it is recommended to it's a lifelong therapy, and this bothers the patients, because the patient after years of treatment, if a patient is treated with cetuximab for 9 years, and there are reports from patients treated for more than 10 years, every 6 weeks. And the question is whether you can stop therapy. And I've stopped therapy in a few cases, and there were no relapses, but there's no data supporting this at this time. But I think in many patients, you have to consider a continuous discontinuation of the therapy after years.
True, sir. Thank you, sir. Dr. Priya Darshini, your question, please. Dr. Priya Darshini, do you have a question?
Thank you very much, sir, for the very wonderful talk. So my question is, if you're suspecting any relapse, should we repeat the lymph node biopsy, sir, to consider it as relapse?
No, it depends on the subtype you have. But usually it's not necessary to rebiopsy. Monitor the CRP, monitor the HHV8, PCR if it's available, and look at the clinical picture. So I would not go for a rebiopsy. However, sometimes you have also keep in mind that some of the patients they will develop lymphoma, and if there's a constant growth, for example, of a lymph node, you have to consider lymphoma. For example, Hodgkin lymphoma, T-cell lymphoma. It depends on the clinical picture.
Okay, sir.
Thank you. Thank you, Dr. Priyadarshini. So I finished all the questions from the audience. Any discussants want to ask any other question? Well, in that case, so thank you so much for a wonderful lecture, fantastic lecture. You were almost to the point. Superb and fantastic lecture.
Thank you.
And thank you for enlightening us on this rare disease, Castleman. I think from tomorrow onwards, we'll have a sharper future for this disease. Thank you, sir. Thanks a lot.
Thank you so much. Bye-bye. Have a nice evening. Bye.